Welcome to episode 3 of Medically Assisted Recovery. I'm James Eade, and I have bent the knee to the tyranny of addiction, and I have struggled to find my way out. And I am in recovery now, and there's a lot of different ways that you can, there's a lot of different ideas out there about what is the best way. And some people think there's only one way. And my experience was it's not one size fits all, that there are many approaches. Some people are a little skeptical of. And when I heard about medically assisted recovery, I wanted to know more because I have learned not to have contempt prior to investigating. So I wanted to investigate more about this. And what I have found has been very encouraging to me, but I don't know very much about it. So I've asked an expert to join me and actually tell me a little bit about what is the experience. Like, what is the first time I go into his office? What am I going to expect to experience? Thanks. And Dr. Gino, you are the expert in this. For me, I've learned so much from you already in episodes 1 and 2, available on airu.tv. We are going to talk today about I've come in for help. I've reached out to you. I have been turned on to you for some reason, and I noted to contact you, but I'm still a little bit skeptical. I'm walking in. And my experience of you is you're pretty friendly when you meet a new patient. You know, you're pretty welcoming. I don't want to put you on the spot, but are you a professional doctor who can be intimidating with a white lab coat on and get someone's blood pressure up, or is it more what's it like?
So first, let me point out that Addiction Change Experts was founded in 2024 with the intention of accelerating access to care. So we created a remote delivery system. So the first thing to know is that most people are not going to walk into the office. If you needed to see me in an office, we can arrange that. I have 2 offices that I work out of, one in Sunnyvale, one in Watsonville, California. Because I'm licensed in California, I'm limited to working with clients that are in California. The license allows me to work with anybody remotely in the state of California. So I can be out of California, but if you're in the state, it'll be fine for me to be able to provide services for you. And then, pharmacies want to fill prescriptions for clients that have a doctor that is, in their state. So all of those things make California as a area where I can provide services. And because I'm a one-man show, it doesn't make sense for me to become a 50-state provider. So right. I provide remote consultation services in California. Our first communication is usually by text. I tell people, reach out to me by text, and then we can find out and coordinate a time for us to have a phone call. And then the phone call is usually an early inquiry saying, hey, what are you dealing with? And let's make sure that this feels like the right fit for you. And then we can schedule a full intake. And an intake with me is very different than a lot of other doctors, because the doctor's offices that you're seeing and scheduling 15, 20 minute, even 30, 90-minute appointments, may feel limiting. So I tell you, we're going to talk for about 90 to 120 minutes, right? Because it depends on how much you have to say. And I'm actually going to listen. I'm not going to try to talk over you. I'm actually going to hear your story and understand where your story has led you. Because it turns out I realize that addiction is not a choice that we grow up with as a child, saying that that's what I want to be when I grow up.
Right.
Right? So, we use substances, we use behaviors, and it turns out addiction is not just substances, right? The big addiction that I've been treating a lot in the last 10 years has been food addiction. Mm-hmm. And we have this tool, the GLP-1s, which I've been actually telling people for the last 7 years, and they finally got out a study in the last 2 years that talks about the idea that GLP-1s help reduce alcohol use. And now GLP-1s can help reduce other substance use. And the idea is that I've been seeing that because I started using GLP-1s for diabetes. As a primary care doctor, I had access to GLP-1s. I saw people that were losing weight and reducing their alcohol intake. Right. And I said, wow, this is amazing, right? This is a great opportunity. So if I had somebody that I knew used a little too much alcohol, and I knew that their diabetes was out of control, and they had a weight issue, I'd say, look, I've got a great medication that can do so many things for you. So that's one of the things that's true about my philosophy, is that because I am a comprehensivist, I am not a single, problem kind of doctor. I've treated all of the diseases, and I know a large class of medication, or multiple classes of medications, and I'm trying to choose the medication that makes sense for your story. So that's why I need to listen to your whole story, and I need to understand your whole story, because sometimes I also can get clued into what were the events in your life that led you to your survival behaviors.
Right.
Right? Because I'm going to bring up a story you shared. You recently talked about, sleep dysfunction or sleep disruption, because for you, it was scary to go to sleep. Right. And so that is a very sensible survival behavior, right? If I'm scared to fall asleep, I'm going to try to avoid sleep. Right. It's not much different with all of these other, I'm going to say, immature coping behaviors,
Hmm.
right? When we have coping behaviors that don't serve us,
Yes.
right? It doesn't necessarily move us in the direction we need to go.
Right. Right. And so part of this is that you are going to help them learn new survival behaviors that are healthier, less unsafe than the ones that we've been using ourselves to treat
Mhm.
ourselves for whatever it is that is haunting us or causing us pain and suffering.
Mhm.
And so rather than taking care of it yourself, which is part of my ego-led belief, was that I could do it myself. And the idea of asking for help was a foreign concept to me. And but I've learned that by asking for help, it was not a sign of weakness; it was a sign of strength, because I
Yeah.
wanted to get help to become the person that could help others. I started out hurting, I ended up healing, and now I'm helping. I can help people now, and so that progression, it did not come overnight. It took a while, but so the GP1 things. This is it's nice that the research that is coming out to validate the experience that you had. You saw it work, and so there's another substance that you use in your medical assisted treatment. That is also going through something similar, and that people would be skeptical of it at first. And the science is starting to catch up to that it actually can be useful. So tell me about, what would you use for someone like me coming in? I have a anxiety disorder, depression, and all of those types of things, including the usage disorder of alcohol. And that's what I use to instead of going to sleep, I would pass out, and instead of waking up, I would come to.
Well, I can definitely, do a talk on each of the substances that
Ah, yes.
we work on in our addiction, treatment. I think that you were trying to allude to the introduction of ketamine as a service that I provide. Um, Ketamine has actually also had recent studies identifying that using ketamine to help people with alcohol withdrawal is helpful, and helping people to transition from fentanyl, which is one of the most
Right.
dangerous drugs on the street today, to a safer medication like buprenorphine is possible and more probable with success when you introduce a little bit of ketamine before they receive their buprenorphine, because when they go from the fentanyl to the buprenorphine, they can have a precipitated withdrawal, and the ketamine can actually kind of quiet that noise so that they can move forward with this other medication, which is safer and potentially a lot more accessible. And
Right.
then we can do different things. So I'm going to say that question was a really big question.
Yes.
Let's focus on you, because you showed up with alcohol and anxiety. I'm going to say that that's actually one of my favorite topics, is that recognizing that moving outside of the FDA approved medication. So whenever I go to these medical conferences and they're talking about how do you support your clients with alcohol use disorder, they always talk about three medicines. And these three medicines include naltrexone, which is,
Yeah.
I'm going to say, something that has come back into play because of the long acting version. And then there's the medication called disulfiram, which is the one that makes you sick if you take it. but you do have to take that 3 times a day. And then there's acamprosate. Of those 3 medications, acamprosate is probably the best, but it's not used that often. And the reason is because you need to be abstinent before you can even start it, right? So
Right.
acamprosate is a medicine that helps people to maintain their abstinence as opposed to helping them achieve their abstinence. And a lot of people that are coming are still struggling with using the substance. And so if they're coming using the substance, first I have to say, okay, well, what is it that is making you reach for the substance? And then I might actually include a couple of medications that can help you to stabilize and help you with letting go of using the substance. And one of my favorites is actually underutilized, and another one that has had some more recent publicity. And I've been using it and talking about it. And when I talk to my addiction friends, they're like, what are you talking about? Topiramate. Topiramate is not a medicine, but it is. And it actually has been coming out in the studies. And so it's another example of where I've been ahead of the game saying, look, topiramate is something that is clearly helpful for alcohol use disorder. Topiramate is something that's clearly helpful for stimulant use disorder. Topiramate was recently FDA approved for food addiction, right? So they put topiramate together with the stimulant, and that combination became a medicine that is used to help people to reduce their eating, right? Because when people were on seizure medicine, topiramate, they lost weight. And they're like, oh, maybe we can include this for our weight loss journeys. But when they used the topiramate by itself, it wasn't great. But when they put it with something else, it worked better. So the idea is that people reinvent combinations. And that's another thing that's really important to me, is recognizing that in chronic disease, one medication is often not enough. And when I was studying in medical school, that's actually how we did blood pressure management. It was like, oh, you maximize the blood pressure medicine before you consider starting a second medication. And it turns out that that was all wrong, right? It wasn't more than 10 years later, they said, oh, actually, if you start 2 medicines, it works better than 1 medicine by itself. And then later on, oh, maybe a third medicine is even a better idea, because the low doses, you can get 8 to 10% improvement of your blood pressure. And the high doses, you got an increase from 10% to about 12%, right? So you didn't get a big improvement with the increased dose, but you got a lot more side effects. And so what I realized is that actually getting a lot of medications in low doses give you a better outcome than taking one big medication at big doses. And a big reminder for that, for me, is methadone. The reason that I'm not a big methadone fan is I see a lot of methadone users being put on very aggressive doses. And the
Right.
reason is because they're only focused on one thing: is, do you feel like you're having trouble, right? And they're not really focusing on the idea that opiate use is often tied to their underlying anxiety, and anxiety symptoms and withdrawal symptoms can feel really similar. And so if you are ignoring the idea of introducing an anxiety medication to someone who has an opiate use disorder, you may not get to where you need to go. So topiramate is a great example, because off-label, it's actually available for anxiety. Off-label, it's actually available for PTSD, right? It's one of the only medicines that I use in MAT that actually has been used in PTSD. Now that it's been FDA approved for weight loss, I think it's one of the only medications I have that's in the psych category that doesn't promote weight gain, right? Even one of the medicines that's similar is gabapentin. Gabapentin is another medication that a lot of my, I'm going to say, medical colleagues have adopted, right? I see people coming out of the ER with gabapentin for alcohol use. I've seen that Stanford has a benzodiazepine sparing alcohol withdrawal protocol, which primarily focuses on gabapentin, loading dose, higher doses, tapering over a few days. But the idea is that gabapentin causes weight gain. Topiramate does not. So if I was going to choose one, and I'm choosing something in someone who's maybe weight sensitive, I definitely want to move towards topiramate. Is topiramate wonderful for everyone? The answer is no.
I don't know how to spell topiramate.
Yeah. So the brand name is Topamax. And then if you Google Topamax, you'll find topiramate. But it's Topiramate, topiramate.
Okay.
And so Topamax,
has one more time.
Topir. I think it's IMATE. Okay. I pronounce it topiramate because that's how I can phonetically spell it, right?
Well, that's what I'm going to.
But Topamax, if you Google Topamax, And the
Okay.
version that's in the weight loss is actually, new. It's the extended release version, which is why, that's how drug companies make money, is that they change the formulation and then okay, now I can charge you more money for it. But the shorter acting version works just like naltrexone. Naltrexone is a medication that has been available for
Yes.
decades and has always potentially been a benefit for alcohol, but we weren't using it that way.
Right.
And now they put it in a pen. And this pen injection is a higher dose that lasts for a lot longer. It's a 30-day at a time injection, right? So
Wow.
28 days, 38 days, 30 days. And so the idea is that that medication really helps to turn off your pleasure. That's what it does. Turns off your pleasure. So what is the side effect? Well, actually, it can actually cause you to have more depression, right? Because if you turn off pleasure, it's not like it only turns off pleasure for alcohol. It turns off pleasure for opiates. It's actually FDA approved for both opiates and for alcohol. And it turns off your pleasure for everything else, right? Naltrexone is also one of the medications that's been FDA approved in a combination for weight loss, right? So it turns off pleasure for food.
Right.
Naltrexone is a medication that the nice thing about the long acting injectables is that when people are having a hard time making a decision every day to take medicine, this medicine just is there, right?
Right.
And you do have to go in and get it. There are some programs, for example, some of the pharmacies have started providing this injection, so you don't necessarily have to get it directly from your doctor, because
Wow.
pharmacists could do that injection for
I
you in
did
some
not know that.
places.
That's interesting. That makes it
But
so much more convenient in a way.
yeah, I mean, that's the idea, is that if we can find some ways to reduce the restrictions or the limitations for receiving these medications. So you can get the consultation remotely from someone like me, and then I can send you to an Albertsons pharmacy, right? Or a Safeway pharmacy. And if you can find one of those in your local community that can provide you with the medication, they can do long acting injectables for things like naltrexone. They do long acting injections for things like buprenorphine, which is a different topic, not related to alcohol.
Right.
But for alcohol, I would say, look, we've got these 3 FDA approved medications. I've got topiramate, which is one of my favorites. I've got gabapentin, and then beyond that, the opportunities for MAT for alcohol are not as clear. But basically, all of the depression medications, all of the mood stabilization medications, all of the psychotic medications could be used, right? Because someone says, "Well, I have trouble sleeping." I was like, "Oh, well, let me find the one that makes sense for you to help you to sleep."
Yeah.
Right?
Yeah. So
Sometimes it's a sleeping depression medication like mirtazapine. Sometimes it's a sleeping antipsychotic that helps with anxiety, like quetiapine or Seroquel. So,
what,
all the time we have to just realize, okay, what is it that you're dealing with, and what do you need support with? And then I'll try to find one of the medications that's in basically the lunchbox of psychiatric medications
yeah.
that could potentially help you.
Well, that's fascinating to me, and what I really am hearing and appreciating is that you spend a lot of time learning about the patient
Yeah.
and getting to know their story, getting to know what is their what is causing their anxiety, that kind of thing, or what is it that you want to treat? What is the medical assisted treatment that is appropriate for this person? And so, the use of appropriate technology in so many ways, like, don't put up a water energy source in the desert, put it where there's a lot of water, where there's waterfalls and stuff like that. These are the types of things where appropriate, making it, because you have to like meet people where they're at and to say what they need to hear and give them what they need that'll help them, rather than one drug for everything. And
Right. I
I
like the expression that it's hard to build a house with only a hammer.
yes, yes, yes. So we will meet again. I have to wrap up this show now, but I so appreciate. I'm learning so much from you, and I encourage people to reach out. And oops, let me see if I can pull your number up again. Yes, there's scrolling across the bottom of your screen now. It's Dr. Gino's phone number. Send him a text if you think you need help. And if you're wondering whether or not you need help, you probably do. And, it won't hurt. It's just a text. And see where it goes from there. Who knows? You might be onto something that changes your life for the better. So, Dr. Gino, thank you so much again for your time and your expertise on a fascinating subject that I knew so little about.
Yeah. Well, I appreciate you being open and extending the knowledge so that more people can understand that there's more than one way to find recovery.
That is the message that I've been trying to send. Yes. And whatever works for you, use that. And thanks again. And